Hello everyone. So again we have two x-rays here. In the first x-ray you can be able to notice that all this tooth structure is gone. There's more than 80% of the structure loss in the coronal part, and then even in the periapical region there's a large periapical lesion associated with both the roots. And then coming to the second radiograph, you can see that there's a complete destruction of the tooth, including the root, and also there's no periodontal support to the tooth. It just feels like it's standing in the air. So yeah, the better option for both these cases would be extraction. So you have decided to extract the teeth. So the patient is starting the treatment and you have numbed up the patient, you have given a good block, and then you start to elevate the tooth. And the minute you start elevating the tooth, patient again complains of pain. Now you want to reconfirm your block and you start reconfirming your block and you ask the patient for the signs and symptoms. And the patient confirms that all his tongue is numb, lips are numb, and his gingiva is numb. Everything is numb and your LA is working perfectly fine. Your block is working perfectly fine. And then you go for an infiltration and then you start elevating the tooth. Again, the patient still complains of pain. So, why does this happen? And what will you do to control this pain? So, the first things first, why did this even happen? Because your block is working well, but still the patient still feels pain. And like in endo, you can't call it a hot pulp because you're not working on the pulp anymore. It's the periodontium you're working. You're extracting a teeth. You're not performing an endo. So you can't call it a hot pulp. But there should be a reason that the LA is not working. Why is it? That's primarily because all this area, whichever you see as a radiolucency, or even this periodontal part, all this has a lot of inflamed tissues. So when these inflamed tissues are there, there's increased blood supply with a lot of inflammatory agents, and also the pH of that area changes. So with a lot of inflamed tissue over there, there's a constant blood exchange happening over there, and because of this increased vasculature, there's less efficacy of the LA to be present over there and act for the long time. And the second reason is the increased pH, where the area becomes acidic and your LA is already acidic. So acidic and acidic will not actually work well. For your LA to act, it should have a neutral pH. So now what should you do to attain that anesthesia and extract it without that pain? All that you have to do is increase the local drug availability. And how do you do that? Because you have already given a block and you have already given an infiltration also. So how do you now deliver the drug locally? Would you give another infiltration? Because we are discussing about the local drug delivery. Are you thinking of infiltration? No, that's not what has to be done. All you have to do is to switch to intraligamentary anesthesia. When you go for intraligamentary anesthesia, it's very important that you give the anesthesia into the PDL space of the tooth. As shown in the figure, the needle should aim into the PDL space. And while doing it, you give it on all the four sides of the tooth. You give it on the mesial, you give it on the distal, you give it on the buccal, and also the lingual. You give it on all four sides of the tooth, and then you start elevating the tooth, and the patient is much more comfortable and will not complain of pain this time. Now, by what mechanism does this intraligamentary anesthesia work? Now we have two scenarios before, like this is the first and the second scenario. In the first scenario, where you're giving an intraligamental anesthesia here, and also on the buccal and the lingual sides. So when this is given, just like your intrapulpal anesthesia, this acts on all the PDL that is present here, and then it creates a lot of pressure over the PDL and it severs the PDL. and the PDL is now lost so that your extraction becomes easier. In the second scenario, in your second case, you're giving the intraligamentaries here, and all that. Now, in this, what happens is, because there is no bone over there, all this area is free and ready to receive the anesthetic liquid that is given. So when you give this anesthetic liquid, there's a lot of liquid present in that area, so there's increased concentration of the anesthetic agent, so that actually works as an anesthetic agent, not by severing the PDL, because there's not actually PDL present here, because all this has been become a soft tissue and inflammatory tissue, so you can't say there's a PDL over there because it's all covered now. So in this two scenarios, the mechanism is completely different. First, in this case, it's by destroying the PDL, and in the second case, it's by acting as a local anesthetic by increasing a lot of concentration in that particular area that the anesthetic is available in that area. Whatever mechanism it is acting, but it still acts very well when properly given. And do follow this method, that will make your extractions much more easier whenever you have an abscess tooth or a mobile tooth. This works well. So from next time when your LA is or your infiltration or block is acting well and still the patient complains of pain, you don't have to actually tell the patient or try to convince the patient it's only pressure, it's only pressure, it's only pressure. You don't have to give that rhyming to the patient. You just do this one method, give an intraligamentary injection on all four sides of the teeth, and proceed with an extraction, and your patient will definitely thank you.